Hey, good morning, good afternoon, everyone. Thanks for joining. My name's Rich Delperdang. I'm the SVP of Sales at Event Health, and I'm actually the moderator for today's session as well. And for those of you who haven't joined before, this is our October Roundtable, where our panel of health plan and industry experts will discuss how health plan leaders can develop and deploy a practical guide to better navigate RADV audits and ensure audit success. We have the pleasure and we're thrilled to have a guest speaker today, Marty Riza. She's a skilled healthcare professional who drives compliance and accuracy in healthcare data. She also specializes in risk adjustment for Medicare, Medicaid, and ACA plans, and is an expert in clinical documentation improvement, provider education, and successfully managing CMS and Health and Human Services HCC RADV audits. I also have the pleasure of introducing our founder and CEO, Ro Bardwat, and I also have our Chief Product Officer, Siva Tunga, joining the call today as well. I asked Ro if he would join the call and maybe towards the end kind of weigh in and provide his thoughts towards the end of the session as well. So with that said, I'm going to go ahead and start the call. For the first slide, I want to make sure we understand and review that RADV isn't just about passing an audit. It's about how well our health plans function day to day. Go ahead and go back to the other slide, Nihat, if you could. From a documentation to coding compliance, RADV really reveals how strong or how fragile our infrastructure really is. So for payers, for providers, the stakes are high. We understand accuracy for reimbursement. Compliance drives trust and both protect the integrity of our programs. So today's roundtable is really about practical guidance, what you can actually do to strengthen the audit readiness and also close gaps and avoid costly surprises. On the call today, we'll take a closer look at the most important factors shaping audit success and the strategies leading to organizations are using to stay ahead. So with that, let's go ahead and move into the discussion part. Next slide would be great. So for today's agenda, what we're going to do is take a quick look at where we'll start on a high-level overview of RADV components. We'll move into key compliance areas and common pitfalls the plans are facing today. We'll then spend most of the time discussing practical strategies and really how to prepare effectively and what best practices really work in the field. Our goal is to make this conversational as actionable as possible for everybody joining. Next slide. So we're going to kick things off and start with the fundamentals. This slide really gives us a quick level set on the key players and the types of RADV audits and the financial compliance implications behind them. It's also important context before we get into the deeper discussion ahead. So with that said, I'm going to kind of start with some questions to our esteemed panelists. And I think probably the first few that you're going to want to hear is from Marty, from her experience and from her lens of what she's managing today in her life. So I'll start with a couple of questions to our panel. The first would be, of the key stakeholders in RADV, plans, providers, coders, auditors, CMS, which groups present the biggest challenges in alignment and why?
Hello, Rich. Thank you. I would say that definitely the biggest stakeholder would be the health plan, right? And of course, we have CMS, but really the alignment really needs to take place internally. So I would say the biggest challenge is really the internal alignment that needs to take place way before you get the notice from CMS. So really, I'm talking about the medical record collection, the attestations that need to be collected, having the coding team ready, ensuring that we're selecting the best medical records, working with our internal compliance, and ensuring that the data ultimately makes it to CMS. So I find that, to summarize, it's really the alignment that has to be taken place internally.
Sounds a little bit, Marty, like the old saying of herding cats, being able to get everyone to pull together to kind of support the charge that you're leading.
Yeah, absolutely.
The next question I have for the panel is, different RADV programs exist. Obviously, we know Medicare, ACA, Medicaid. How should a health plan prioritize resources when they may be subject to multiple types of audits going on simultaneously?
Yeah, I can answer that as well. So currently in my organization, we actually have three lines of business. So we are DSNP, so we have the Medicare, we do have an ACA and the Medi-Cal. And I'll tell you that this is a good time for organizations to take a look at their head count, knowing that our landscape is changed, knowing that it's not a matter of if we will be called into a RADV, it's when. So having that conversation with your leadership and really being ready, having those tough conversations. And I will tell you, it is very labor intensive, depending on the scope of the RADV and your resources to prioritize, because I've been in a RADV at other organizations on the MA side where we had the coders actually collecting the medical records. In fact, myself, I actually went out to many hospitals and collected medical records. So, it's kind of thinking about, okay, what are the resources we have? Can we hire? Should we hire? Does it make better sense that we do so? And then now that we're in the space of multiple RADVs going on, it's really about the timing. I think on the ACA side, it's a little more predictable because we know when that will take place. So, typically July through November, December. But with the new RADVs coming out, we're still not sure. And so we want to make sure that we have those conversations well before we're hit with multiple audits at the same time, and really start thinking about prioritization prior. So what is that going to happen if we have multiple? Who's going to, go where and do what? And do we need to hire additional team members? Do we need to work with outside resources to help us with our medical record collection? Those kind of things. So that's, really a conversation that needs to take place now as part of standard operations for the health plans.
Great. Thank you, Marty, for that feedback, that insightful feedback. I realized I didn't formally introduce our Chief Product Officer, Siva Tunga, who's on the call as well on the panelist session. And I'll take a moment to see if anyone else on the panel would like to provide any thoughts or feedback on some of the insight that Marty provided.
Yes, thanks, Rich. One of the key things when it comes to RADV is what are the tools typically are available for you to be able to complete the RADV on time, or because each RADV or the type, as you explained, the typical RADV types, each one has a different time windows where you need to complete or close the activities. And there'll be a lot of stress across the teams because the alignment, like what Marty said, internally needs to be there. Do you have the resources who are actually parsing all the data readily available to reconcile the data, as well as, okay, what charts you need to pull, which are more critical for you when it comes to the charts to be captured? Do you already substantiated? I think the more important is how do you prioritize, and how are you able to give guidance to all your stakeholders, because there are multiple people involved in this process. One is your coding team, who is actually reviewing the charts and ensuring that they are submitting the data. Then your retrieval team, who is trying to figure out which charts are more critical or which providers I need to outreach and work on that. The third one is basically your leadership team, who is more important to know how much does it impact me if I don't substantiate this, right? Because this is where are we falling in your extrapolations, or where are you falling within your RADV compliance compared to other competitors, are like state level comparison if you're doing it from an ACA or a national level benchmark. What we see is these three have different needs and the data looks similar, but many times technology wise you need to give a clear picture for everybody to know what is priority to work on. The coders need to optimize their time to know I'm doing the right chart audit or reviewing it and submitting it, because the submission process it's also is tedious depending upon you are an IBA vendor or are you working with another system to upload the charts, what's the naming conventions. All those things play a role, and that's where your ITs and tools vendor whom you are supporting should have the capability to handle those and support that from end to end. My leadership is looking at prioritizations, and resource alignment. My coding team is looking at ranking of the charts to work on and what charts I have available, how quickly I'm making the charts available for my coders. My retrieval team is looking at what's spending, who is prioritizing me, the activities.
Thank you, Siva, and thanks, Marty, for your feedback and your thoughts on this. Maybe we'll move to the next slide. Now that we've really established the foundation, let's shift a little bit to compliance. The area that's really determines the audit outcomes. From documentation standards to submission integrity. These focus areas define how well prepared a plan is when it comes time for the actual review. And I think this is an area where having this feedback from our panel and from the experts would really be important to ensure from a compliance standpoint that you're checking all the boxes in advance. So the first question I'll propose to the panel is, documentation is obviously at the heart of RADV. Where do you see the biggest gaps in meeting the MEET criteria today?
Yes, so that's right up my alley. So definitely as a coding manager, we do oversee different projects throughout the year, such as sweeps. I mean, we do quite a bit of provider education and outreach. And definitely, the documentation is the area that we spend a great deal of time on. So for what we really see the biggest gaps in the MEET is really when we see providers not documenting any supporting evidence of the condition being active, or we don't see any treatment, or we're just not sure of is it current? We often see maybe a listing or bullet points of codes without any other information. So we do notice these things, especially when we're doing our retrospective chart review, and we definitely we do collect this data when we see it, and we make sure that we deliver this information back to the providers after each project. Of course, this is also something we look at when we are deciding what providers that we want to really reach out and do some in-depth provider education. And so this is definitely a topic of discussion that we have with many providers because we do see it, and we ultimately try to instill upon the importance of proper documentation, really, which supports best, is best for patient care. So that's kind of our message when we do see this, and we definitely make this a priority to discuss with our providers.
That's great feedback, Marty. Obviously, improving outcomes is important. A lot of people focus on the financial impact as well, and the financial performance. So I love the fact you're mentioning patient first, profitability second. So thank you for sharing that. Second question I have is kind of a long question. It's what patterns or systematic issues do you see most often when providers fall short of MEET criteria, and how can we tackle them upstream rather than downstream? And what role can NLP and AI play in reducing provider burden while strengthening documentation quality for RADV?
Yeah, I'll answer that one primarily. It's a combination of operational efficiencies as well as technology, what it can help, right? One is how quickly I can identify that there is a gap, because we are talking about compliance. It's not about pulling the chart towards the end of the year and doing a retrospective audit for only the charts which you can actually pull or review. The goal need to be more strategic in terms of how I can identify these early where there are potential gaps, whether there are comorbid conditions or the patient is kind of taking medications, but there is no reference of the diagnosis in the charts or the claims that are submitted. So there are a lot of kind of data points as well as triggers which can be identified at the beginning as well as during the process of coding as well during the course of the year. That is important for us. And if you have the systems in place where you can actually pull the charts more concurrently, we need to establish that ahead of time, because that's one area where we see where, like previously Marty point, provider education, it's an ongoing process. You might need to do more like a quarterly provider education on what you're learning. As you can see, as more data is coming in, more learnings can come, and you would be able to take that feedback to the providers early, take it early and get it resolved rather than waiting for the entire year. So like quarterly, biannual reviews and sending the feedback as reports, establish a channel through which the data can be pushed to the providers on potentially the care gaps more. That way, you're more focusing on the outcomes as well for the members. That essentially is going to help in addressing some of the compliance issues and not worry about RADV as a more like a, oh, there is my governing body who is asking me to prove. If we follow certain steps, proactive outreach for the members and providers to look at the ones which have gaps, you have tools which can support you to kind of do that one. Because the biggest challenge again is as more charts come in, like what Marty pointed out, how many resources I can put in to kind of work on those. As a health plan, as a team, you have a limited number of resources. That's where NLP can really help. NLP is kind of natural language where it can analyze your unstructured medical record data and point out where potentially there are gaps or where we identify those, and whether it is gap could be positive gap or it could be negative gap. Those both you have to look at it from an adds or a delete of a condition perspective and make sure that they are accurately reported to CMS. The second point is submission integrity, where it comes is do you have the right encounter submission process? Are we missing any data submissions? Or did we link or associate wrong records and submitted the data? We have like reconciliation processes to be able to track them, and you have complete visibility for your team and attesting that this is matching the medical record, what it was submitted. So we need to establish those reconciliation processes as well in order to reduce a last minute hurdle on collecting the charts, as well as identifying, oh, we missed this, not captured, etc.
We see, but thanks for the detailed feedback. It's obviously a pretty arduous process, so we appreciate the insight and the detail of what the plans are looking at and how we can assist. Now that we've covered compliance, let's go ahead and go to the next slide. Let's look at where this tends to break down, whether it's documentation gaps, coding inconsistencies, or provider alignment issues. Really understanding these common pitfalls is the first step to preventing them. This helps kind of set the stage for what effective preparation looks like. And I'll go ahead and jump to the experts and run a couple questions by them to weigh in. First question is, from overcoding and under documentation are two sides of the same coin. Which risk do you see as more common and why?
Yeah, I think, in general, we do see that the code selection oftentimes does not match, the level of documentation. And of course, that could lead to both under and an over coding. But ultimately, it is inaccurate coding. So we definitely do see that quite a bit. And, we do identify these issues. I mentioned provider education because it's so key for us to have these conversations with our providers. And, like Shiva mentioned earlier, doing it consistently, whether that's quarterly, biannually, but whatever that is, to make sure that it's consistent. And, hopefully we see our providers improve in this area. But we probably see a little bit more of the overcoding than we do the under, although we do see, like I said, both. And again, through the provider education and feedback and reporting, we do identify these issues and use this information as part of our discussion with providers.
Thanks, Marty. Appreciate your insight. Second question I have in the common RADV pitfall areas, from a data mismatch between electronic healthcare records, coding systems, and submissions are frequent. What technology or process improvements could close this gap?
Yes, this is more from technology or the process what you can actually create in the system, right? If you have EMR system access, that would be the first step where you would be able to make sure that you are able to access the data and identify, because that is the data source of the data for all your claims and data when the member is visited or encountered by the provider and capturing the data. So we have seen, I'll give a good example. We have seen many cases where the data is present in the medical record, but it is not submitted. That's again primarily because of what we call truncation of diagnosis codes. Because when it gets submitted to CMS or Medicare or your 837 format, because we are going into details, you have a limited number of diagnosis codes to submit. Now, does your EMR system is capable of capturing all diagnosis codes? And is it submitting all diagnosis codes to your health plan? If not, that is one area where you need to keep looking at what are the typical members, looking historical conditions, and is there a place where you can identify those? The second one is most times missed is like your comorbid conditions or the conditions that are typically documented but not reported consistently, especially with your specialty providers, because again, those providers focus on the condition that they are currently being treated, but the patient might have all the underlying conditions to be reported. They will not be assessing, but they'll be using them as part of their overall assessment of the conditions. Now, how are we identifying those providers and flagging them when that conditions are occurring? Because there are opportunities with your prior authorizations, your care management platforms, where you can actually pull that data and link it. The bottom line from the overall process, if you see, right, the data reconciliation coming from different data sources, whether it is alternate data, claims data, your supplemental data or EMR data, how you are able to identify those data mismatches, reconciliations, and keep bringing them or highlighting them for the teams to work on is very critical. What Marty pointed out, provider training and compliance, these data points, you need to break it down. What are your key categories you can look at it? Is it a data truncation issue, or is it an overcoding issue, or is it undercoding issue? We need to give specific examples as part of that. Do you have a dashboard or a view which can constantly bring that information at a provider level so it can be easily presented to them, as well as enable them with the data points for discussions during the conversation? Because you need to show them with the right examples, then providers will be able to enable or update them in their systems as well. So that's key for us to work on. The last point is more related to what we talk about what we call member attribution, is like how you're engaging with your members, and are we aligning it to the right provider to be able to match, whether they are trying to do the AWV visits or any in-home assessments. Are there follow-ups after the in-home assessment when there are certain conditions which need more follow-ups? You need to be able to have systems which are tracking this end to end. It's kind of what we call a journey end to end, from that where you're starting from prospective, you're looking at it, an ongoing process, concurrent coding, then you're going into retrospective coding. All these ones should be able to identify and capture those gaps, what we call RADV pitfalls. You need to have, the most important thing is, there are a lot of learnings, and even OIG publishes those, what they call common errors they're identifying. How do you bake that into your tools and technologies to support that? That is also very important for us to have the systems which can understand what are the common errors they make and highlight those as high risk conditions and report it for actions.
Helpful, Siva and Marty. I have appreciate your feedback. Under the common RADV pitfalls, I have one more question, and I think this one's probably right in your wheelhouse, Marty. how can health plans move provider training from a compliance checkbox to something that genuinely reduces the audit findings?
Yeah, great question. I think providers, they're now aware that the RADVs, that they definitely are part of our landscape, right? And that compliance and being audit ready is something that is really not necessarily, it's part of what is currently, like I mentioned, the current landscape of today. But that really means for us at the health plan is really taking the opportunity to create better relationships, but not only with the providers, but look at their ancillary staff, the office managers, the billers and coders, and really get to the root cause of any documentation compliance issues. At my organization, at the end of the year last year, we actually did, going back to Shiva mentioning the data, how important that is to be utilized for these type of situations. And we did look at some outliers. So we looked at some outliers on risk scores, and we did a deeper dive. And we actually went out to visit these providers individually and had a conversation about their end-to-end processes, from documentation to how the codes are selected and ultimately sent over to the health plan. And we saw some interesting things. It's really important that as much as we have our conversations with our providers, we really need to take a look at their end-to-end processes, because we did see that some of the offices they used billers that were using some old information, like they have their cheat sheets from years back, and incorrect codes, outdated codes, old codes, just wrong codes. We saw, a lot of that, or, the use of ChatGPT. We saw a provider utilizing that, but not in a favorable way, of course. So having those conversations about what does that look like, and how can we really ensure compliance all the way end to end, and not just at the provider level, but looking deeper and using the data to help us with that, so that we are identifying those, and we are looking at the outliers, and we're looking at offices that have a high a higher than normal rates in certain conditions. So I think that's a strategy that's been helpful for us.
Thank you for that feedback, Marty. Let's go ahead and go to the next slide.
Rich, I think we have an audience who asked a question in the chat. Do you guys want to address that, or do we have a separate Q&A in the end?
We have a moment at the end. We're kind of opening that up, unless it makes sense to address it when we're on that topic.
Yeah, okay. Marty, it's more on the, we'll address that in the end. If you have taken that note.
Okay, we'll circle back. Thanks, Ro, for calling that out. Now let's move into identifying the issues to take action. Preparation is really strong. Plans focus and stand out. They do this through solid governance, proactive risk assessment, data quality controls, and ongoing provider engagement. That is where audit readiness becomes a year-round discipline, and the success that they have as well. And to make that all work, focusing on a few questions I have on how it's been successful for Marty, and as well as Siva's insight as well. So from preparing for RADV, obviously chart retrieval is often cited as the biggest operational hurdle. What practices have made this process more efficient?
Yes. The first step where we see pitfalls, like I think this question somebody asked is quite relevant to this one when we are answering it. One other challenge health plans face is, once, because the RADVs are done so late, now that will change definitely as CMS is pushing for more frequent or complete all the audits soon. But when it comes to the charts pull, the provider systems are not holding the data longer period of time, or if the provider or the clinic is closed, they don't even have the charts, or they don't even have access to the charts. As per CMS, unless it is a catastrophic event like an earthquake or a flood, you don't have an exception for not having the chart to be able to substantiate for the member. That becomes very critical, and that's where we now need to really look at the enablement of technology as well as the capabilities you have. One is how much of charts you're able to collect for the members, because if you look at it, all the members who have a HCC condition, you can identify who are your high risk members, where the conditions are potentially for an audit or capture risk. And you can actually flag those and say, I need to have a process to be able to pull those charts and keep it in-house. First step. The second process is essentially if you have EMR integrations or like access to your EMR system, as a process, you need to have a dedicated process to pull those charts, whether they are really impacting your process or improvement in your risk scores. I think beyond that, we need to look at it as a audit requirement. And that's what the health plans need to adjust or align going forward, how they can actually bring those charts early and have that information in handy. The better preparedness is very important for us when we talk about the audits to be captured. The third part is moving into more of a prospective process to pull the charts or prospective engagement with the members. Means audit can happen only when there is data where you're not known that the patient is not being monitored or managed more effectively. If the patient is being consistently managed with like active programs like AWE, annual wellness visit, PCP visits, E&M visits, which are truly capturing the conditions, then we might not have that issue. Now, can you optimize that process using some of your prospective programs so that you have a better visibility to capture? Like even if you're engaging a vendor for in-home assessments or any other type of telehealth visits, how do you make sure that you have guidelines or capture those data more accurately and report it? The last part, I'll focus more on the data quality and technology. Again, you need to be able to leverage the reconciliation as we speak about data reconciliation at all levels. When it comes in just 837 data coming in, can we identify high risk conditions and capture them? Or are you seeing any primarily like a single occurrence conditions, like only one doctor reported the condition, but no other doctor is reporting those conditions for the member? Those are your high risk members, and you always need to have the tracking in the system so you can actually be able to pull the charts and take actions on those. That is where you need combination of technology support. It's not about number of resources. Optimizing that with the help of technology, use NLP as well as integrations which will allow you to analyze the charts and close as much as the gaps as possible.
See, but chart retrieval is obviously a big operational hurdle, but provider engagement is critical as well, but also challenging. I'm curious from the panel, how do you motivate your providers to participate, actively in the audit preparation, kind of without feeling burdened?
Oh, yes. Well, I kind of wanted to backtrack a little because I think Shiva mentioned something so key about the chart retrieval. Before we move on, because that is a very good question about the providers feeling burdened, and I do have a lot of thoughts on that. But kind of circling back, I think Shiva mentioned some really, really key points about that. I would just say that really is probably one of the toughest things for an organization is getting the records. So whether that be you're working with a internal team to do so, or even an external team, I think some of the challenges we face is that, we have a claim on a certain condition from a certain data service, and you go to collect the chart and they say, oh, that we don't have it. Those are some things that also, I think those are conversations that you have to have and think about why, there should be a chart. why is there not a chart? And especially like Shiva mentioned, the high risk, if that, let's say that is the only provider that documented that condition, is even more key. So I think those are conversations that just going through RADVs now that we're starting to have with our leadership. And what does that look like? How is that escalated in your organization? Where is compliance in this? And how can we make sure that offices understand the significance of, proper chart maintenance, so to say, so that when we do these chart retrievals, that the data is there when it's needed. So sorry, I know I went a little off, but that was just something that was really significant, and I thought, I should mention it. But that being said, I will move on to the question about the providers. And, I think you mentioned how provider engagement is critical. And then you also mentioned the word challenging, and it is. I'm not going to sugarcoat this. It's not easy. Keeping providers engaged in the process is something that we definitely work on as a health plan. And providers do feel burdened. We know that. We're not going to, say that they don't. We do understand. And, I think whatever it is that we message to the providers, I think the importance is, being consistent in our messaging. But, providers they're aware of the audit risks. We do identify deficiencies through our retrospective chart reviews, as I mentioned earlier. We also identify the incorrect code selection. So, we're able to generate reports and have these conversations with the providers, and then show them the results and provide education on that. But again, it's acknowledging the fact that we understand that they are burdened. There is a lot of expectations, and really engaging with them and letting them know that, we're here, we're your partner. We're here to help you. We're here for support, and we're not here to, overburden you, but to also make them aware that, that these audits are real, and they do take place. They will be taking place. And, it's really important, but really emphasizing how important it is. And I mentioned earlier, to patient care, having a well-documented chart based on the member's true patient acuity, and having that information make it from point A to point B, right, all the way to CMS is ultimately the goal, and best for the patient. And when that someone else reaches out for that chart, and there's a good documented chart with, proper having the member's severity of illness really demonstrated is, really critical. So having these conversations more and more with providers, I think they do understand the significance of that. And we also message to them that the documentation doesn't need to be a novel. It just has to be concise and clear. And, as whether or not the conditions are active in the treatment plan. And, we also make that so that they don't feel burdened that they have to create these novels when documenting. So again, just consistency, feeling their empathy. I've gone into a provider's office where it just was not a good day for me to be there. He had members waiting in the office. He had an emergency earlier. And, here I come with my reports, and it was kind of like, I could read the writing on the wall. That was not a good day for me. And rather than me continue to push while I was there, I just took a step back and, just acknowledged that I understand, and that when the timing is better, I'll be back. And so having that dialogue and just really understanding the burden that providers face will really help in the long run.
Marty, that's really resonating with me. Having your providers be an extension of your operation, and making sure they're involved in the process is pretty critical. So I love the fact you're sharing that, and thank you for providing that feedback. Why don't we move to the next slide? I think we're right on track from a timing standpoint. So really to kind of wrap things up, we'll look at what best practice or best-in-class audit readiness truly means. We find that successful organizations don't just prepare once a year, they integrate readiness into everyday operations. Obviously, consistent playbooks, mock audits, cross-functional alignment keeps teams ahead of the curve. And I wanted to ask a couple questions. to the panel that really support that mindset. So if you're looking at how effective having a mock audit is, and what's identifying blind spots, what makes them most valuable?
Yes, the mock audits are one of the things which we need to perform, or it's kind of need to be mandated. As we explained, right? We have a lot of tools and learnings, and the mock audits helps in resonating that learnings and reflecting that in your providers to outreach as well. And it helps to kind of avoid the last minute pitfalls when we have the audits come in, because it helps in preparation for the real audits as well. What we mean by that is identifying your example of high risk conditions, where you can take the OIG toolkit as a reference point, where they reported 8 conditions most commonly miscoded or not documented incorrectly. That's a good learning, and have we baked into your tools to be able to flag those conditions and without a proper treatment or medications? Do you have the technology to support that? The second point is more like undercoded or underdiagnosed conditions, which typically happens again in certain cases like diabetes or sometimes in cancer, which is where you're not completely capturing the conditions when the patient is undergoing treatments, chemotherapy, or multiple conditions reported for those. The third point is it gives you the providers who are kind of your common error identifiers, or you can say that your kind of problem childs, right? To be able to pick those providers and kind of enable them for provider education as well, because that way you are able to identify those high risk providers whom you need to focus on. That really helps to kind of create your own process and enable that for capturing the conditions early and documenting it as well. So if you have a risk sharing model or a delegated model, mock audits are going to be more like a precursor, or bake it into your contracting as part of the process.
Great. Thanks, Eva. So many organizations are struggling with the siloed teams. I hear this quite often when I'm sitting across the table from our partners. How can compliance, coding, and clinical teams work together really in a unified workflow?
Yeah, I can take that one. So I've worked at organizations before where there were silos, and I think, in general, organizations, they don't mean to silo. It kind of happens. I think that we all have our area of focus, that we have our deadlines and we have our commitments. And I think sometimes it just happens that certain departments and teams that should really be united tend to silo. So I think it's important to identify, take a good look around your circle and say, wow, are we siloed? Did we become siloed? And if we have, what can we do to remedy that, right? And how can we eliminate that in the future? I think for us, or from my personal experience, what has worked is that understanding that there are many moving pieces, at the health plan level, not only at the health plan level, but just in all levels when it comes to the RADVs, that have to be really committed to the process. It cannot be done by just one team, one department. There really does take a lot of cross collaboration. And I think it's a really good time to take a look at your policies as well and say, wow, do I have a policy to represent what happens in the event of a RADV? What needs to take place? As our compliance teams really understand the significance of what does it mean operationally. Of course, they understand the compliance of it, but the operations that take place to make a RADV happen. Are we having those conversations? How well do we know our compliance partners? I mean, that's talking about silos. I mean, I know in my organization, I make sure that these are our buddies. We're going to work together, and we want to make sure that they have an understanding of the process. So when that notification comes, that we have a policy in place that outlines what takes place from point A to point B, and again, working with the data, taking a look at our the chase list, identifying the medical records. I mean, we talked about that, how important and getting in the medical records, working with the coding team, making sure that the coding team is ready for that. But, really the important piece is, of course, all the naming conventions that Shiva mentioned earlier, getting that, those are little things that you don't think about, but they make a big difference and they are time consuming. And so we want to make sure that we have those policies in place, that we're ready, because I'll tell you, not being ready for these audits is probably one of the biggest pitfalls that we can do. And thinking that we got it together, thinking that, okay, having it all appear, but not writing anything down, those are mistakes. These are things that have to be well planned, well organized, well socialized amongst your peers, your community, your partners, your compliance, your leadership. Leadership, needs to understand, of course, the resources and just how many moving pieces they are. And these audits are getting shorter. I think in the day they were 24, 26 weeks, and I know that they are just significantly shorter, although I did hear they expanded it a little bit, but a lot has to be done in those few weeks. So there's no room for siloing. So really, again, my advice would be take a look. If you're not already in good communications with the teams that you will need for a RADV, I would highly suggest that you do so.
Thanks, Marty. Can we go to the one last slide? And I had three things to cover, and I know we have 10 minutes left here. And first and foremost, thanks to our panelists for their feedback and their great advice and guidance for our partners on the call today. But I have three things I wanted to, number one, give Rose some time to weigh in and provide some of his thoughts. Secondly, wanted to maybe provide some feedback from our panelists, kind of wrapping it up from, a detail from them, broader implications, their final thoughts and reflections, and then obviously answer any questions that I haven't paid attention to that have popped up in the chat. So with that said, I'll hand it over to Ro to jump in here.
Thank you, Rich and Marty and Shiva. I think this is great. You guys have covered most of it, and from your life experiences with your current jobs. But I think the sense, Rich, in my opinion, and what I've seen is there are three highlights of RADV program, right? Number one is provider relationships. So RADV success is almost 80% about how well you can retrieve completely timely records from your providers, right? And that comes from trust, education, make it easy, right? Whether through portals, EHR integrations, or clear communications, and what documentation really means, right? And I think I'm highlighting back some of the things that Shiva and Marty talked about, but I think that is very important. One of the questions Rick has asked about providers' skin in the game, about record retention for 7 years versus 10 years, the whole debate, right? So I think we need to straighten out some of our provider contracts also, especially for risk-adjusted contracts. They need to be very clear, both with providers and payers. Second thing is, I think they talked a little bit more about the mock drills, which is very important, right? The best run organizations treat mock drills, RADV exercise as real audits, right? It's just not compliance check boxes. So they surface coding gaps, documentation inconsistencies, and retrieval process issues early on, right? Before even CMS ever selects the sample, right? And I think the third important part is the more and more I'm looking and we are working with health and plans, I think getting it right the first time, that's the key here. And that's where technology and process truly intersect, in my opinion, right? Like, for example, Marty did talk about the chase list, and Shiva also touched upon that, right? A coder workbench, for example, that's tightly integrated with your risk analytics platform can make a huge difference, right? It helps prioritize encounters most at risk for RADV, flag documentation gaps before submissions, and drive first time right accuracy, right? That's going to really be helpful down the line versus always be reactive about the entire RADV programs, right? So when your coders, they see analytics driven insights like suspect conditions or incomplete charts, or unsupported HCCs, they can fix issues proactively instead of reactively, right? And that single connection between analytics and coding workflow that I say is what keeps RADV from becoming a fire drill every year, right? So in my opinion, there is this very simple formula, right? Practice early, partner deeply, and power your coders with intelligence. That's how plans can turn RADV from an audit event into more of an operational advantage, in my opinion. I hope that resonates.
Thank you, Ro. Thank you very much. From a chat perspective, I don't know, Steve, I don't want to put you on the spot, but can you take a look at the chat questions, determine if we have time to address them, or maybe do a follow-up email with answers later? Let me know, again, based on where we are.
I can answer that one. Maybe Marty can chip in the question. I think what the simple question is, the provider network, the recommendation is to capture the record for up to 7 years, whereas CMS or request that you should be able to have up to 10 years. Or as per CMS, you need to have the medical record whenever it is requested, because the audits can happen any pretty long period as well, or you can say any lawsuits or any challenges. You need to be able to support those. The best way in this one is have proper contracting with the provider. In the provider contracts, it need to be clearly established. If it is risk adjustment, it is mandated that it needs to support what CMS would require, because that we don't have a choice. As I said earlier, the CMS RADV audit, the exceptions are only provided when there is a flood or a catastrophic event like an earthquake, where they cannot retrieve the records. If the doctor is deceased, or if the clinic is no longer functioning, it is a health plan's responsibility to be able to have those medical records in handy. So that's your provider network team becomes critical, how you are able to work with your member records and see what's the risk. When even if provider is going out of contract, what is the risk you have? Because will you be able to collect the chart if I get into an audit? Because there is always that provider contracting which changes whenever there is. And that's important that you have language as well as the contracting established to be able to support what CMS requests than what it is defined as the standard. Yeah, Marty, I don't know if you have any thoughts or recommendations from your experience.
Yeah, no, I think you really hit it there, right? Shiva, you're right, the contract. I think that is key. I like I said, this is something that I think recently became awareness to the audit that we're currently in. And, I think we had to take a look and well, how are we remedying this? And, having that look at the contract to see what type of language do we have. And you're right. What happens if they do go outside of the contract? And what do we have in place for that? So I think those are definitely areas for health plans and organizations to take into consideration and make sure that they have those policies ready. And also the contracts are up to date, so that when and if this happens, there are actionable items to take place. Yeah.
Thank you, Marty. I know we have a couple minutes left. I have a couple questions just to maybe kind of wrap this up. I'd love to get your insight here. What's the biggest lessons learned you'd shared from your experience kind of navigating OIG or CMS assessments?
Well, I can speak on that. Well, kind of a twofold, because you mentioned lessons learned, and then you mentioned how I believe the OIG or CMS assessments have assisted. I will say that from a lessons learned perspective, just being in RADVs before and being in one now on the ACA side, it's all about preparation. Not waiting until the last minute, not anticipating that things will run smoothly. I think you have to anticipate that things are going to happen. You have to be ready. Allow yourself ample time, because things could be running really smoothly And then ultimately, you're going to get that fork in the road or something that happens that will just derail. So I would say that would be my aha moment from being in RADVs. And secondly, I do remember when the OIG toolkit came out, and I thought, wow, I think it was back in 2023, something like that. And I just remember thinking, wow, there is now something to support. I think we've always known some of those conditions were being inaccurately documented. And I think to have the support of the OIG to, really now have a document that we could share. And even to this day, it is part of our toolkit internally when we plan, when we're looking at outliers and, things that we want to provide education on. So definitely a game changer when that OIG toolkit was released.
Thanks, Marty. I see one other question that popped up from Rick, and I think this one may be one we want to follow up on an email. Rick, we have your email address, and maybe that would be more appropriate to respond directly on that, unless Siva or Ro feel like they want to weigh in. If not, I'll definitely get back to you, Rick, on an email. I think that probably would be appropriate. Last question.
Yes.
It's a very interesting question, Rick.
It is.
We do have an answer and also an opinion. We'd like to share that with you in the email. I think we're running out of time, but very interesting question. Thanks for asking.
Thank you, Rick, for sharing that question with us. Last comment, last question from a technology standpoint. We're all talking about AI, automation, predictive analytics, et cetera, and how they shape your RADV preparation for the next 3 to 5 years. Would love maybe somebody on the panel to weigh in just with final thoughts on that.
Yeah, Rohit, you want to try that, take that one, or you want me to answer that?
Rich, can you please repeat that again? I got distracted. I was rereading Rick's question. Sorry.
Oh, no, that's fine. I was just kind of talking about all the different requests from a technology standpoint with AI, et cetera, and analytics and how they reshape RADV prep over the next 3 to 5 years. What does the crystal ball say as far as how those technologies would make life easier for our helpline partners?
Yeah, like I said before, Rich, it's all about getting it right for the first time. And I keep repeating that even for all our clients, there is not enough meat left on the bone when it comes to the risk adjustment membership itself. There is a lot of scrutiny. There is a lot of going to be audits going forward. Even if this gets stalled, there'll be another one where we need to get this thing right. Marty did point it out earlier also. And I think you need to integrate that. Very, very close integration has to happen in 3 layers in my mind, right? Your analytics should be able to create those chase lists, which are very accurate, which member that you're going to go after. If you're going to chart retrieval, then how do I make sure that they are matching with my claims that I have? So which are the conditions which match the claim, which are the ones which don't match the claim? How do I empower my coder to be able to identify these issues at the chart review level itself, or when we get those charts? And how can I make it even it's just not about the chart chase all the time, but how can I make it more lean and efficient and make it cost optimized, right, from that perspective? So that's very, very critical. And what you submit back to CMS is going to be what you will be audited on. So let's try to make sure that layer is clean, the pipe is clean. And second, I think there's a huge focus on the provider relationship, education, and also making them part of the journey, right? So your provider contracting, I think Marty did talk about that in the end. We need to relook into our contracts with providers also. And, sometimes we need to sit across the table and say, look, if RADV is going to ask me for 10 years, you need to support me for 10 years, right? Period. I need to have these records at your side available so that if I'm asked for, you should be able to supply back those to me. But at the same time, since plans are the ones who basically bleed the most, I would say that we need to have those technologies like integration with the EMRs, make your providers more enabled. So what can I do for my provider to make those providers more successful so that they lead to my success, right? It's kind of a loop. So I want to make sure that these technologies, which is like analytics, coder workbench with NLP, and also the integrations with EMRs, or if not integration, then can we give a provider portal where provider can see, okay, these are the documentation gaps for each member that I can start, helping me document more going forward. Does it make sense, Rich?
It sure does. And thank you, Ro, for that feedback. I'll go ahead and close the call out here. Thank you, Marty. Thank you, Siva. Thank you, Ro, for your great insight and feedback during this call. Thank you for the participants who took the time to invest in this session, and appreciate everything. We'll follow up and respond to the questions we received. And again, appreciate your time and thank you for joining today.